And thank you, David. Wanted to officially welcome you all to the 2023 California Initiative to Advance Precision Medicine ACES Research Symposium. This year virtually. We were delighted to launch this series last year in person at UCLA, when we were graciously hosted by Dr. George Slavich and his extraordinary team. Happened to be on the same day that Vice President Kamala Harris was in the building. So that was a unique experience to share the space with such a tremendous leader and Secret Service and their dogs. But here we are in the virtual world. And I've just the briefest opening remarks before handing it over to David and some of our respected members for additional welcoming remarks. But just want to reflect on, these 3 years now since almost 3 years since that initial launch of the RFP. Am I saying that right? Actually, 4. My goodness, it'll be 4 in December since we launched the RFP. Then we were all hit with COVID, and just recognizing how the community really came together to push back each deadline to give you all space to handle the crisis and put together the most incredible project teams with those community partners, many of you with far more than the minimum of a singular community partner, and just how proud we have all been to really uplift your work with the legislature, with our fellows across executive branch in the Newsom administration. We've been working also with the NIH very closely, National Academies of Science. Everyone is interested in how our projects are pushing forward this innovative approach to the innovation pipeline, with the development of new federal agencies for health research, including ARPA-H, as well as some additional work being done and considered by BARDA, CDC, and other agencies. So we're really delighted to bring you all together. We recognize just what a feat it is to find time on the busiest calendars of our network. So we thank you so much. I don't want to spend any more time before handing it off now to the MC for the remainder of our symposium, Dr. David Reiner. For those of you who haven't had a chance to connect, Dr. David Reiner started in April as CIAPM's science officer. He spent 5.5 years at the NIH as a neuroscientist, studying fentanyl relapse, opioid relapse, and 18 years in total in neuroscience research labs. So we're so lucky to have him, and as the program officer for our ACES portfolio, as well as other demonstration projects. So David, without further ado, happy to hand it to you.
Thank you, Dr. McCall. It's a pleasure to be here, and I've met many of you, and I'm looking forward to meeting you in person during site visits coming up in the next few months. And I'd like to welcome you all to this ACES Research Symposium. I'm honored to dive into the symposium, to start by introducing California Surgeon General, Dr. Diana Ramos, to provide them opening remarks.
Thank you so much for the opportunity to welcome all of you as you share your innovative work on ACEs. We know 61% of US adults are experiencing at least one ACE, and with 1 out of 6 experiencing 4 or more ACEs, the innovative research and studies you are all working on is fantastic. I had a chance to read the summaries. I was presenting this weekend in Newport, Rhode Island on ACEs and reproductive health to OBGYNs from primarily the East Coast. And interestingly enough, the concept of ACEs was new to them, relatively new. But when I showed them the opportunity to actually make a difference in preventing not only chronic disease, but some of the most negative perinatal outcomes that we all face, the question started to happen. What can we do? How can we get started? And more importantly, what is new? And that's where I want to highlight that all of the work that you're doing is so critically important to not only California, but really to the rest of the country. With 1 in 8.5 people in the United States living here in California, you are really making a difference nationwide. So thank you for all of the work that you're doing. My office is here to help support your ACEs work, and I look forward to hearing the updates that you all will be sharing. Thank you for the opportunity.
Thank you, Dr. Ramos. With that being said, Julianne, would you mind sharing the screen again? We'll briefly go over the agenda. So we'll dive into research presentations. As you can see here, first by Dr. Pat Levitt, then by Stanford team, Loma Linda, UC Irvine, UCLA. Then take a break and go into presentations by UCSF and UCSD. Then we'll have a discussion session, and we'll have some framing questions to guide that discussion, and we'll go into closing remarks. So with that being said, I'll introduce our first speaker, Dr. Pat Levitt. And before I get to that, Dr. Levitt has requested that we not record his presentation. So I'll pause the recording now to our next speaker and restart the recording. So our next speaker team is from Stanford University. I'll first introduce Dr. Sayantani Tina Cinder. She's a clinical associate professor of allergy and immunology and director of clinical translational research at the Sean Parker Center for Allergy and Asthma Research at Stanford University. She couldn't make it today, so I'll introduce several other members of the Stanford team who will be presenting on her behalf. First, Dr. Rachel Gilgoff is an adjunct clinical associate professor of pediatrics in the Department of Allergy and Clinical Immunology at Stanford, and a clinical science senior advisor for Aurora Health Group, ACEs Aware Initiative, and the Center for Youth and Wellness, a program of Safe and Sound. Dr. Gilgoff has a vast array of experiences and expertise, including as a child abuse pediatrician at the Center for Child Protection at the UCSF Benioff Children's Hospital and Research Center in Oakland, as a co-investigator with the Bay Area Research Consortium, and as a medical director of the Clinical Innovations and Research Team within the Center for Youth Wellness. Dr. Alex Addo-Boteng is another speaker from the Stanford team. She's a director of perinatal mental health integration project programs at the California Health Collaborative. She supports birthing people, moms, dads, and their families at risk of a mood disorder through partnerships with medical providers, hospitals, and behavioral health providers to create a comprehensive plan of care. Sue Kincaid is a program director of the Fresno Community Health Improvement Partnership, where she leads the development, expansion, and sustainability of their initiatives. She draws on her business and broad nonprofit expertise and experience in developing organizational infrastructure, fund development, communication, and increasing reach and impact through collaborative strategic values-based leadership. They're also joined by another team member, Christine Martinez from Stanford. So with that, take it away.
Thank you so much to CIAPM for this opportunity. As you said, Tina is in Portugal right now giving a talk, but she sends her gratitude as well. And thank you for introducing our great team. And we have 3 members here today. As you said, Christine Martinez is our clinical research manager, and nothing would get done without her. So thank you so much, Christine, for being here. And our brilliant and passionate Fresno partners, Alex and Sue, and you already introduced them. So thank you so much. I'm just going to talk for a minute, because I really want to give Sue and Alex some time to talk. But just to say on the Santa Clara, so we're a partnership across Santa Clara County and Fresno. On the Santa Clara County side and the research side, some of the challenges, and I would love to have discussions with all of you later about some of these, is that we've found it's easier to get experimental biomarkers than it is to get what I thought were the basics, such as epinephrine and oxytocin, which I thought is kind of interesting. It's, tricky to recruit for childhood diversity when our healthcare system doesn't acknowledge childhood diversity often, and that the pace of academic research, budgets, and contracts has been a little tricky in creating smooth collaboration with the community and relationship building, but really appreciative of our community partners for their patience and skills. and relationship building with us. That being said, I do want to highlight two really exciting opportunities. We have started recruitment, and that's going well. And I'm excited to say that we submitted our first paper on stress biology framework that we're employing in this study. And we did that in collaboration with George Slavich's team, who's on this call. So thank you, George. So fingers crossed. And again, really grateful to our Fresno partners and the community-driven network of care that they've developed. So I'm going to turn it over to Sue and Alex. Thank you.
Good afternoon, everybody. I'm very pleased to be part of this project, and we're very honored to work together with this group. I'm going to give you a quick overview of FCHIP in the Fresno community, just to give you a glimpse of the collaborative health equity work. FCHIP's purpose is to build collective power for community resilience, especially for the most vulnerable in our community. Next slide, please. To give you a little context about FCHIP, I would like you to know that we collaborate with other collective action networks to amplify equity and inclusion. For instance, we're currently working on a community information exchange to facilitate data sharing. FCHIP is also part of the statewide California Accountable Communities for Health cohort. Next slide, please. So this diagram shows how FCHIP brings in multi-sector health-focused partners with over 100 partners participating in any one of our initiatives or overall in some of our convenings. We address health disparities and inequities through prevention and addressing barriers to access equitable, inclusive, culturally and linguistically appropriate healthcare, mental health, and social services. And you'll see that the FCHIP initiatives and work groups align with the ACEs Aware Stress Buster Wheel. We're very committed to creating a trauma-informed community and integrating trauma-informed practices to understand how toxic stress and ACEs affect health outcomes in our work. We are doing this by training providers, youth, CHWs, community-based organization staff, and community residents on the science of ACEs. We're educating clients on how toxic stress affects health, connecting those families to health, mental health, and social service resources. And we work to advocate for and influence policy for equitable and inclusive policies. You also notice that our other collective action partners are represented in the green bubbles there. So Cradle to Career focuses on education. The Children's Movement develops residents who join councils that affect change in different areas such as mental health, childcare, broadband access, all important for overall health and well-being. The DRIVE initiative focuses on economic mobility and neighborhood empowerment. So working together, we really kind of get the whole picture of the community and are able to address some of the barriers that our most vulnerable are experiencing. Next slide, please. So how did FCHIP come to integrate trauma-informed care and resilience building in our work and in the community? It started in 2017 when one of our primary partners launched the Trauma and Resilience Network work group to address the high ACEs and toxic stress experienced by the most vulnerable in our community. We began by training a few people to become trainers in ACEs science. Then in 2021, we launched the ACEs Network of Care, which provided a referral system relying on CHWs to connect patients to CBOs and agency stress buster resources in our community. And this was possible due to our network and the partnerships we had established. By 2021, over 2,000 people had received trauma and resilience training. And by now, I believe it's close to 4,000. So we're still doing that training and that work. By 2022, we were well established to receive funding from our local Department of Public Health to implement a community and evidence-based care coordination model with FCHIP as the hub. The model tracks risk factors from identification through mitigation and links payment directly to outcomes, relying on CHWs as care coordinators. We're the largest Pathways community hub in the country with 6 partners and 25 community health workers. This all sets the stage for the upcoming project you'll hear about from Alex. Thank you.
Thank you, Sue. So it's Alexandra from California Health Collaborative. So California Health Collaborative has several projects and programs that we offer. I have oversight of all of our perinatal projects throughout California. I'm just going to touch on our Fresno projects as it would be related to this project. So we have a home visitation program, and then within that home visitation program, our staff are screening moms for ACEs, screening moms for maternal mental health complications, and screening moms for social health determinant drivers. With our Fresno perinatal substance abuse project, we are looking at changing systems within Fresno County, allowing moms to access services both with OBGYNs and then treatment for their substance use. For our ACE project, or our AIM project, that one encompasses looking at infant mortality and morbidity. Next slide. So this summarizes essentially what we do. We have stakeholders within our communities. It's usually OBGYNs, psychiatrists, pediatricians, and we hold these stakeholder meetings to just allow individuals to look at gaps within our county and then mitigate those gaps. So moving on to the alignment of this project with California Health Collaborative. So currently we have to recruit our moms, whether again at the OBGYN's office, if it's at maybe a WIC, any sort of setting where mom and babies engage, which is pretty broad. So we plan to take that same tactic here with recruiting our participants. For this project, we want to look at individuals who are scoring a ACE score of 4 or more. And then from there, we will case manage, we will work with the individual participants directly, and we will utilize the HOPE pathways model that Sue just mentioned to ensure that our individuals understand stress busters, healing strategies, and it's really this wraparound service for our participants. Within Sue's hub, it's okay. Within Sue's hub, her community health workers, as she mentioned, have created pathways to community resources that allows us to not allow patient clients, members fall into gaps. So we do appreciate that. And I think Sue and I are both going to speak on this, so go ahead, Sue.
It's some of the challenges that we are facing is that Stanford is far away, and so trying to find a way to conduct the study has been a little challenging. To bring 30 participants to Stanford would have been a little tricky. So we have worked out something where we can do that here locally. So
thank you. So as I mentioned, California Health Collaborative is a nonprofit. So shifting to blood draws and clinical research is new for the collaborative. We're excited to take this on. Opportunities. So continuum of collaboration throughout Fresno County. A lot of us, we've been working on this for years, kind of decreasing silos, getting everybody to work together to really impact our community overall. Sue's project years ago, I'm not sure of the exact date, started really working and honing in on that ACE training. So I think that this is kind of our next step for Fresno County, being able to say, leaders in our community receive this ACE training. We're implementing ACE training or ACE surveys, but now we'll be able to measure that. Would you like to add, Sue?
yeah, I'll just say that the hub staff will be also collecting all the data as the participants go through the pathways, and we'll be able to show that those pathways were closed or remain open and why they were not closed. So we'll have a lot of additional data and research to provide.
And the bigger picture, we're hoping that this project helps influence both local policies.
Mhm.
Next slide. Thank you.
Thank you. Any questions? And here are all our email addresses.
Go ahead.
Oh, sorry.
We have a couple hands raised, but Ariane, since you're
Oh, I'm sorry. I'm having trouble finding the hands raised thing. So anyway, I was just gonna, Rachel, I hear that the intervention group was described. Is there a control or a comparison group?
There will be, yes. So we're going to have it's more of an exploratory study, but we will have about 30 participants with an ACE score of 0 and about 100 participants with an ACE score of 4 or more.
We'll go in order of hands raised. So Jessica, you're at the top.
I'm at the top. I love that. Okay, so my question for the team was about the HOPE pathways that you had mentioned. Is that similar to the HOPE model that Dr. Bob Sege is doing at Tufts University? It's something that our team has been exploring as well. So I'm just curious if you all have any more insights about that.
Yeah, it's actually based on the Pathways Community Hubs Institute out of Ohio, I believe it is. And it's an evidence-based model that pays for outcomes. And so I'm not familiar with one you're referring to, so I can't really say if it's similar. But you can look it up, and it's community-driven data.
Great, thank you so much. And Dr. Heckler just put in information about what I was referring to. So good to know. Thank you.
Yeah, it's a different great HOPE.
Dr. Ramos?
Yeah, I just wanted to comment and say thank you so much for including the home visitation programs. When we're looking to work with our partner and our sister agencies, this has been one of the recommendations to include the ACEs screening in the home visitation programs. And I'm so pleased to know that you're doing that work already. So it would absolutely is going to be a good example for the rest of the home visitation programs in the state. Thank you.
Thank you.
Dr. Amatoso?
Thank you. Yeah, I was just curious in terms of with the hub and the network, how does that connect with the medical home for the pediatric patients? And what does that look like?
So the patients in the study can be referred through the hub, and if they don't have a medical home, then they can be directed to a primary care physician. Is that what you're referring to?
Yes, that's what I meant.
One of the barriers that we're finding with perinatal women is that sometimes they'll look for a pediatrician, but they won't find a family health provider. So our care coordinators are trained to start having those conversations about a medical home, insurance, especially some of our women, most of our women are accessing medical health services. And so with the shift to they have to go through this re-eligibility process. Our care coordinators make sure that they do that as well.
You're bringing up an interesting piece that we probably will want to do some qualitative studies with Center for Youth Wellness around, in that in Fresno, we're going to be recruiting directly from the community through FCHIP and CHC. On the Stanford side, we're actually going to be primarily recruiting from perinatal OB clinics and from pediatric clinics for caregivers, as opposed to directly recruiting from adult clinics. So it'll be interesting. And part of what we want to look at is how supporting the parents actually helps impact child health and child health outcomes. So that's our next research and grant that we're looking for.
Thank you, everyone. And thank you for the rich discussion so far. We'll keep it moving. The next speaker is Dr. Ayan Marie Mitchell from Loma Linda University. She is an associate professor of preventive medicine and pediatrics at the School of Medicine and School of Public Health at Loma Linda University. Dr. Marie Mitchell's research includes understanding links between psychosocial risk factors, biological markers, and health outcomes, and the development of primary care interventions to assess risk and improve outcomes. She also performs primary preventative care at Loma Linda as well. She is joined by her team members, Amrita Rai, Daniela Ramirez, and Carmen Vega, all from Inland Empire Health Plan. Take it away.
Okay, all right. Do want to thank all of our partners on this project, but a special thanks to IHP, which was critical right from the start in terms of funding a pilot for this work, and has been providing our community health workers, or we refer to them as family mentors. So I am going to try to keep an eye on the time and keep it moving. Right. Giving you an overview of what this project is about. The slide again, where we are screening for ACEs in pediatric practice. And we've been doing that for a while. And this study is first looking at the association between those ACE scores that are reported and possible toxic stress. And then looking at whether our intervention, which we are naming here first, or families implementing resilient systems together, whether that basically shows any evidence of reducing stress and improving outcomes. That is the overview. And then this is the overview of our research evaluation, where we are looking at both no ACEs group, and then two groups with ACEs, one that has usual pediatric care, and the other one that receives one or more of the 3 levels of our intervention. And so what I thought I would share with you is basically what we've been spending our time on in terms of the workflow around the intervention, and then evaluating, did we actually change behavior with the intervention, and then just some preliminary slides on looking at the impact of this intervention. So several slides here on workflow. This is a modified version of what we submitted for the grant. Again, there's 3 different levels. One is what happens in the pediatric practice, which is shown in blue. And we've been busy every year training new cohorts of pediatric residents who we're working with, as well as our faculty on being more comfortable talking about ACEs and resilience, stress management, healthy relationships. And then for families where there's a concern, connecting them to our community partners, where a community health worker meets with that family by phone or in person. And then the 3rd level, as we envisioned it, is the family classes. We've had trouble basically with uptake with the family classes. So we've kind of moved it around and tried to create several different ways to let families know about these classes to encourage that participation. So in terms of getting into the weeds, part of what we have wrestled with is we're 2 main clinics involved, but our primary site is a resident clinic, which is also an FQHC, which is blessed with multiple different resources for families. But that has just meant that we have had to, in terms of doing this ACEs work, coordinate it with other things. And so in parallel to our work on the ACEs was a rollout of an intervention for social determinants of health, and that was really confusing to our physicians. And so we ended up creating this common pathway, this one order, where basically if there's any psychosocial concerns or developmental concerns, because one of our key partners is Help Me Grow, that there was just one order to place, and then we have an orders manager who basically receives that family that's been identified of concern, and then based on these responses to these different questions, whether the family's interested in the parenting curriculum, if there's concerns about developmental delay, where the family is located, their insurance, that determines basically which partner receives this referral. And then also built in is all sorts of sort of crosstalk between the partners because they have different areas of expertise. So wanting to sort of utilize expertise for developmental concerns and other things. So that is that. And then in terms of the once the family or I should say we make the referral to the community health worker or mentor, they reach out to the family. We have been also piloting having our IHP partners in clinic, and it's always nice to be able to do a warm handoff when possible. But we have found that when we are able to reach families by phone, that this works just as well. And then they basically do an assessment to have a better understanding of how ACEs, as well as other stressors, including social determinants, impact the family, address what's needed, and check in with the family again at 6 and 12-month follow-up. This is actually in the process of, being updated, I'd say. Basically the pink and red area is a sort of new pathway that we've recently added to try to encourage that enrollment in the family classes. And the original curriculum that we were working with in Nurturing Families is a 16-week curriculum. But in order to encourage participation, we are revising sort of how we advertise it to families and encouraging them to come to one or more of the classes, advertising it as an 8-week series that they can then continue if interested, and providing some incentives for those who want to do the classes along with do our research evaluation. So that was the details about the workflow and what we've been trying to implement for our intervention. And then, as I say, a good part of our effort has been looking at, well, okay, we did these trainings, has it made a difference? So we did a pretty large chart review where we were matching by both child age and ACE score, and then comparing the physicians who were trained versus the ones who were untrained. And showing that, yes, the trained group is doing more counseling about ACEs, also handing out we have 3 different handouts that we've prepared around this topic, and they are general, offering handouts more. So that's one level. And then looking at the referrals, that, it's all well and good to make referrals, but, most referrals don't actually happen. That's true for us as well, but we've been tracking that and doing what we can to improve the success rate of those connections to our community partners. Our community partners, when they do get a chance to meet with families, do a great job with identifying and addressing social basic needs and a variety of other things as identified here. And then we, just like for our physicians, we're working on training those community health workers to be comfortable providing education about managing stress and building healthy relationships. You can see this recent assessment. This is just for the months of September and October, and this is just for our partners at Help Me Grow and Loma Linda in terms of their documentation of counseling and providing handouts. And so the last thing, but definitely what we're interested in getting at is, are we impacting outcomes? And again, our research evaluation is looking at that, both looking at biomarkers, but also looking at child health outcomes and school performance. So don't have any of that data yet, but to see again, are we moving the needle a little bit for these families? So I'm referring to this as sort of the combined pediatrician CHW intervention, because basically all of the families, in this case, this is a sort of within subjects analysis. So everybody saw a trained physician and then did successfully connect with a community health worker. And then this is what that community health worker sort of summarized for the family in terms of initially basic needs that were reported. And then at 12-month follow-up, you see that there was basically a reduction in basic needs for these families that were supported. This is also within subjects, and this is looking at the promise scale, and you have both the individual items where the higher bar suggests more concerns in those areas. So you want to see at follow-up, which we were in general seeing a trend toward a reduction in the concerns, and the overall global physical and mental health scores improved for families at the 12-month follow-up. So again, this is just preliminary small numbers, but suggesting that we're going in the right direction in terms of impacting families and reducing stress. And last, we did a chart review. This is the pediatric chart review, and we're looking at concerns that were addressed. And we didn't see differences in terms of other types of diagnoses, but what jumped out is that for the families, and this is now between groups. So the CHW group is again the folks who saw the trained physician and the CHW, and then we compared that to families who were also referred, but either declined seeing the CHW or we weren't able to contact them. So that was our comparison group. And you see that the group that was supported, more of their kids had visits that were addressing concerns about speech delay, ADHD, and autism. In terms of our next steps, well, you see them listed there, but I think I'll just leave that up and see if in our last few minutes we have any questions for myself or potentially for the IHP partners.
Are there any questions for Dr. Marie Mitchell or the IHP partners?
I don't have a question. I just wanted to say it was really nice to see those data at the end. It feels good to know you guys are impacting those outcomes.
Yeah, I will say, and I think it's okay if I share that it's, I think especially for our IHP partners and the other groups as well that have been supporting these families, we know we're doing something good. I mean, they see the stories, and it's just been like effort to like get it down to numbers that we can show the impact. Yeah.
Dr. Omatoso, go ahead.
Yeah, thanks for sharing. I had a couple of more follow-up questions. One was, for the CHWs, is there a formal training process they're undergoing? And this was existing staff, or this is new staff?
I wonder, well, I'll just answer the ACEs part of it. So we do basically a 4-hour training with the CHWs in terms of this basically semi-structured interview that we encourage them to use at the initial visit, and then a shorter version at the 6-month and the 12-month follow-up. And then we also provide support in terms of managing ACEs in monthly case-based discussions. So that's what we're offering, but I don't know if anyone from IHP wants to add about the sort of this is all on top of the basic training that they have.
Hi, this is Carmen from IEHP. Thank you, Dr. Mitchell. So for our CHWs, or we call them health navigators, they do go through formal training once onboarded here at the managed care plan. So within our department, they go through about a 6 to 8 week training of very formal health navigation, not only of understanding the managed care plan in its entirety and in its whole and the different departments that we service, and as well as the benefits offered via the recipients of being members with IEHP, but the health navigators also do a lot of formal training externally and working with various community-based organizations and understanding the community as a whole. So they are certified CHWs with various skill sets and training. That's not only within just the onboarding, but we also do formal training every month, every quarter, and then there's annual training as well. So the training is very consistent with the regular cadence to keep them on their toes and to make sure that they have the proper skill set to be able to handle what they encounter, not only working at the SACS clinic with the residents and providers, but also what they may encounter as they do conduct home visits, and being able to have the skill set, whether it's via the BH component or again, the physical component or around social support that's needed. And I will defer over to my director if she has anything else to include in that. And Amrita?
Hi, Carmen, thank you. Honestly, she said it well, and we really are extremely blessed and honored to be participating in this with Dr. Mitchell and the SACS clinic.
Yeah, I will add that it's a very good question that you asked, though, because we have more than one partner on this grant that we initially proposed to provide to CHWs, and IHP definitely has one of the higher standards in terms of the training and the consistency of that training across. We unfortunately lost one of our partners over exactly this issue because as a research evaluation, we wanted to make sure that there was comparable level of training and support being provided. So.
Thank you.
I know there is a question that was asked. Yes, there is a standard. The state is working on a certification component around CHW work.
I think that standardization is going to be key because we're not the only clinic. Many around the country, as more and more healthcare organizations try to figure out how to provide a support for families, are wanting to use CHWs. But obviously, standardization around what training and skills they have will be helpful to know exactly what is being added.
Great, thank you. And if you want to continue to use the chat to add context or details to the conversation, feel free. In the interest of time, we're going to keep things moving on with the next speaker, Dr. Tali Z. Barham from UC Irvine. Dr. Barham is the Danette Shepard Professor of Neurological Sciences and Brandon Distinguished Professor of Pediatrics, Anatomy and Neurology, and Director of the Conti Center at UC Irvine. Her research interests focus on the influence of early life experiences on brain maturation and the implications of these enduring changes on neuropsychiatric diseases. She is joined today by her team members, Dr. Laura Glynn, Fong Dao, Dr. Charles Golden, and Dr. Mike Weiss. Take it away, Dr. Barham.
Great, the unmute button misbehaved. Really, can you see my screen and can you hear me?
We can see your screen and we can hear you.
Fantastic. Well, it is really a pleasure to be here today, and I was really inspired both by Dr. Diana Ramos and Julianne McCall about the challenge of really using precision medicine to tackle the impact of adverse experience in childhood. And it's really fascinating and really inspiring to see what the other groups are doing. So thank you all for putting this together. Well, we will be spending the next 10 minutes discussing, we meaning myself and Laura Glynn will join, is really telling you about the project that we have about really trying to understand if we can predict the impact of not only existing ACEs, but actually a undiscovered or not well understood challenge, ACEs on neurodevelopmental outcome. But first, of course, I'd like to start with the team. So we have a preclinical team at UCI because, like Pat Levitt, we're using a cross-species approach, taking a clinical problem and studying the mechanism in experimental animals in mice and rats, and then taking it back, and I'll show you how that works. And then we have a team at Chapman University run by Dr. Glenn at UCI, again, the team of bioinformaticians, actually a provost who's a statistician and a variety of people, and amazing community advocates. There is a robust group at CHOC, and we have here with us today Michael Wise and Charlie Golden and Feng Dao. And we have a terrific community advisory board, and I'm only giving you some of the people's names in here who have taught us a lot. So what are we actually asking to do? Well, we have two goals in our proposal. One is to actually add a 5-item questionnaire to the ACEs screen, because we think we may have discovered and really understudied type of adversity that spans ethnic and socioeconomic and worldwide communities has really not been well studied. And Laura will tell you more about that. And we're aiming to go for 100,000 infants, and Laura will tell you where we are already. The other is really to try to individualize our ability to predict not only who has ACEs, but actually who has been impacted. Because we all know, as I'll tell you in a minute, that although two kids may have had the same experience, they may not necessarily have the same outcome. And that is actually beautifully explicated in this particular study. I mean, we all know that ACEs are not particularly good for us and have very well described outcomes. But what this paper shows us, that this is true mainly at the population level. In fact, this is what the group, I mean, these are the two largest prospective studies in the world, really showing that the more ACEs you have here on the y-axis, the more likely you are to have mental health problems and physical health problems as a child, and actually even as an adult. And that is exceptionally robust at the population level. But when the same authors, which are the leaders, began to look at the ability to predict for an individual child, as you can see here, this receiver operating curve is not as well as we would, is not as powerful as we would like it to be. To be able to predict if Johnny, who has had 3 ACEs, is really going to do poorly, and Julia, who has had no ACEs, will do well, we need a curve that will look like this. As you can see, the actual data are not as strong as they could be, and not a much, much better than chance. So our question was really what's missing. And I'm not going to share with you here 10 years worth of work as part of the Conti Center and individual laboratories of our team, that we actually found that unpredictability of signals from the parents, from the family, from the neighborhood is really an unrecognized adversity. Using experimental models, we went into the brain and we figured out that it impacts how the brain circuits that really execute our behavior, our emotion, really are impacted in that case. And we're working on this in parallel with what we're doing with the California Initiative. In children around the world, in Finland and in California and elsewhere around the world, it really appears that unpredictable signals really influence both intellect and mental health, and I'll show you that in a minute. But the other amazing thing about it is that unpredictability is actionable. Just like we've heard here from other groups, you can train individuals to actually provide predictable and consistent care. So this is really what drove the current project that we have. And the first aim, I'm going to stop talking and ask Laura to chime in and tell you about the first aim. Take it away, Laura.
Right, so we have 2 very different but complementary aims, and this first very ambitious one is, as Tally said, is to add unpredictability questions to the ACEs screening that was already going on in pediatric primary care in Children's Hospital of Orange County, and then also to look at the relative impact of more established ACEs along with unpredictability in terms of developmental outcomes in 100,000 children. So that is our aim. In terms of doing this, you heard Dr. Levitt mention the Quick 5. This is a screening instrument we have developed. It's validated in both English and Spanish. Here you can see the items. In the primary care visits, at the annual well child visits, it's being filled out by all of the caregivers or parents who are there. And then if the child is 12 or over, the child also completes a self-report version of the measure. Next slide. So in collaboration with our excellent set of collaborators who you already heard about at CHOC, we have now implemented screening in 19 clinics across Orange County. You can see here that we really have representation of the geographic diversity, which also is correlated with sociodemographic diversity. We're really representing the county, and my understanding is that CHOC serves 70% of Orange County's children. So we're really getting a nice representative sample. To date, and this is already out of date because I have yet to receive the November report from our CHOC research coordinator, but we have received almost 40,000 screens. And this number is really increasing exponentially because we've brought clinics on in sort of batches. So we now have 19 participating, and I think we're going to be very close to that goal that we originally set for the screening. The last thing I'll show you is just some descriptives looking at the type of variability we're seeing in caregiver report of child exposure to unpredictability. You can see on the left, the clinic of the 19 that's showing the most predictability or the least unpredictability, total pediatrics. Seaview and other clinics kind of in the middle, and then what you see is Par Niños on the right, which right now among the 19 has caregiver reports of the highest level of exposure to unpredictability. So our next step is to take these quick scores. We also have the Pearl scores for these 40,000 pairs and start to look at this with child mental and physical health outcomes. And I can report that working with the CHOC data analytics team, we've successfully done a proof of concept data poll where we link these screening scores to a wide range of child health outcomes. So that's where we are with our AIM 1.
And thanks, Laura. Again, I can't stop thanking our collaborators and particularly the CHOC team for the amazing ability to implement this at a large scale, as you have seen, in a relatively short time and with the pandemic kicking in. So thank you again, friends. So we'll move to the second one, which is just as ambitious, although actually in a smaller number of infants. Can we really solve the notion of individual predictability? And what we aim to do here is employ intra-individual DNA metabolomics, and I'm going to go ahead and unpack that for you. So the idea is we really can't get into the brain of kids, unlike in animals, but we all have DNA, and we can go ahead and get DNA actually from buccal swab or from saliva. And the DNA has methyls in it, as you can see here. And many people before us have really aimed to use the pattern of the methylation of the double helix DNA as potentially a marker of disease vulnerability or resilience. The problem has been is that humans are hugely different. And there's so much variance in humans that it's very difficult to really tease anything out, except if you do very large studies and generate Manhattan plots and what have you. Well, we thought we might be a little smarter than that. And what we'll do is we actually will look at an individual child. We will get one sample when the child is a newborn, and another sample from the same child or infant at 12 months. We will know everything we possibly can, or at least try, about their ACEs and through the quick and what happened to them through that year. And we will test the idea that the change in the methylation gives us an idea about a genetic signature or an impact or a kiss or impact of the environment early in life during the first year of life on outcome. And then we will look at neurodevelopmental outcome, and we chose particularly effortful control because the pioneering studies of Moffitt and others really suggested that effortful control is a wonderful predictor of how well a kid's going to do in school and actually also to adulthood. So that was the idea. And we are in the process of recruiting and beginning to analyze that, but we have piloted that idea first initially in rats, in baby rats, and then in a template cohort that is supported through outside funding through the UCI Connie Center. And what is shaping up is the following. First, if you look at the same youngster, at the DNA at the newborn versus 1 year, okay, and again, this is how we're doing it here, We have one at about 10 days, lab visits here, a second one, and eventual lab visit outcome. But if we look here at methylation, yes, we see the effect of age that are reported by many others, and you can nicely distinguish it. If you will, this is proof of principle that the method is working. Second, the idea that we can actually look at outcome is panning out, if you will. If you look at a single sample of a newborn or a 12-month-old, and you see how it correlates with effortful control at age 5 or 54 months, there really is a very, very weak correlation. But if you look in the same child at the change in methylation, and this is 14,000 sites, I mean, I'm not boring you with the technical details. We have a very strong team that is really working with us on that. We are getting here a relatively strong prediction, and that's getting stronger as we bring more people in. The other is, of course, we mention unpredictability, but we are concerned, like everyone, like you, about many other potential variants that altogether interact to predict outcome. And we look at income to needs ratio, we look at maternal depression, although this is not a clinical depression group, maternal sensitivity as well as unpredictability. And what we find in a current cohort is there are weak correlations between income and need ratio and maternal depression. I think this is probably going to become significant when we have more individuals. Very little in terms of maternal sensitivity. And to our almost surprise, unpredictability seems to be a very strong predictor of effortful control. Again, the lower the score in effortful control, the worse the child, and the more unpredictability you have on the quick score, the worse it is. So this is analysis that are now submitted and are in revision in publication from a, if you will, template cohort. The California Initiative cohort will strengthen and validate it. So why are we talking about unpredictability? Well, I think we need to put it in context, of course, with many other ACEs. Homelessness, incarceration. I mean, I'm not going to go through the list because you know it a lot better than we do. But idea is that unpredictable signals from the parent, from the community, are important because they may reflect the impact of ACEs also on the parents, and also seem to influence the brain development as we see in experimental models. So that's where we're at now. In terms of recruiting for AIM2, we promised 120 infants. Julianne, I'm thrilled. Thanks to Laura and Chuck, we've recruited 150. And all sample A have been collected, B is in progress, and we hope to really have exciting data that will jive and hopefully validate what we've done in a prior cohort. A challenge, of course, is that this is a 3-year proposal, and we need 5 years to provide really the outcome, and hopefully we'll all tackle that challenge together. So I'll stop right here and really thank everyone involved, and thank you for listening, and would love to hear questions. Thank you.
Time for questions. We have one already from Dr. Firestein.
Yeah, hi, thanks. That's really interesting. And I really appreciate that many of the challenges of trying to link phenotype to epigenetic changes. I actually have a couple of technical questions on how you're going to be able to accomplish this. The first is that I might have missed it. Are you looking at PBMCs? What is the source of DNA for doing your methylation studies?
Buccal swab, which is a mix of white cells and epithelial cells. And we are looking carefully if we have any change in cell type and the many, many technical aspects of it that we're all familiar with. I think your question is really well taken. So it is the typical Buccal swab, and it's a mix of epithelial cells and white blood cells.
Yeah, I mean, I think that was one of the questions is how you would be planning, and again, it's not for this particular venue, but considering how to deconvolute the data, because
we're doing that. Yeah. So now there are large databases that allow us to look at really a mix of markers that give us information about which cell DNA came from.
And then the other is a question that I keep getting when I submit papers, and I usually have to address them, and it's how you're planning on correcting for SNPs, because the SNPs can also potentially be correlated with disease and outcomes, and SNPs can be largely affect the methylome as well.
So we are looking a priori at the population, both in terms of sex and by, again, the report of ethnic and racial and ancestral mix. and really have not found that that influences the methylome per se. So I think we are addressing here really, if you will, pure epigenetics, completely cognizant of the idea that genetics influences epigenetics. So thank you. These are excellent questions.
Any other questions for Dr. Barham or Dr. Glynn?
I'd like to make just one comment. And again, it was really, really heartwarming, as Laura mentioned, that Pat is using the Quick 5 in his program. And it's easy. It's a minute and a half. And we would love to collaborate with everybody around the table if you care to implement it. I mean, well, English, Spanish. I think it's now in actually 5 languages, Laura. So love to hear from you.
Great, and that's why we bring everyone together in venues like this. Dr. Weiss, I see your hand up.
Yeah, just a quick comment. First, I want to thank Dr. Glynn and Dr. Barham for bringing us along on this voyage, because it's actually been really, really interesting for us as frontline clinicians. And I just want to make 2 very quick points. One is engaging our providers at the front line was very easy because they see the readily translatable nature of this work and the fact that it can lead to interventions now, not 5 years, 10 years, 12 years from now. And secondly is for any pediatricians on the call, I think we have an opportunity to really take this work, and if it pans out, to really look at our Bright Futures recommendations from AAP and determine whether it's just ACEs or whether you need to add something like Quick to be able to get the best view of these kids as a predictor of future challenges, and thus the way to best provide interventions in a proactive way. So thank you.
Any other questions before we move on? Okay. So we have one more talk before the break, and I realize that we're running a little bit behind on time. We'll kind of make up time in the discussion session, and we'll still plan to end at 4 p.m. Just to let everyone know. We're moving on to our last presentation before the break, Dr. George Slavich from UCLA. Dr. Slavich is a professor in the Department of Psychiatry and Biobehavioral Sciences and the founding director of the Laboratory for Stress Assessment and research investigator for the Staglin One Mind Center for Cognitive Neuroscience Research and the Semel Institute for Neuroscience and Human Behavior at UCLA. His research focuses on the conceptualization, assessment, and management of life stress, psychological and biological mechanisms linking stress with mental and physical health, and in systems and policies for reducing population-level health disparities. He's joined today by team members Anna Ginther, Patricia Lester, and Summer Mengenkolk. Sorry if I butchered your name just now and earlier or in the future.
Thank you so much, David. You can see and hear me okay? Okay, yes. Great. Thank you. We can catch up on some time on the end of this talk by just giving me easy questions that I can answer in a second, so that will get us back on track. Thank you so much, Julianne and David, for all that you do, and for the Office of the Surgeon General and Dr. Ramos for supporting this work. I can just say that I wish every meeting that I had was as interesting and cutting edge and engaging as the work that I've heard here so far. The title of our project is Identifying Social Molecular Immunological Processes for Mitigating Toxic Stress and Enhancing Personalized Resilience. And I really appreciate the opportunity to update you on the work that this amazing team has done so far. Aim number 1 of our project is actually a non-research aim, if you will. It's to develop and launch the California Stress, Trauma, and Resilience Network, or CalSTAR for short. And we have some missions envisioned here and key partnerships, and then a few deliverables that I'll just update you on. The mission of the CalSTAR network is to enhance resilience, promote community health and well-being, and prevent and mitigate the effects of ACEs and toxic stress in California and beyond. And our vision for the network is really to develop communities across California that will equitably support individuals across the life course to lead healthy lives and demonstrate resilience in the face of toxic stress response. The key partnerships, of course, with CIAPM, supported the network, and with strategic oversight from OSG, And the partnership formally involves UCLA, Stanford, and UCSF with 3 goals: advancing science, engaging the public, and training future leaders to develop a workforce of equity-minded, stress and resilience leaders and researchers. We have some exciting updates on a few of our deliverables. One of our deliverables was to launch a research training program to help individuals across the world prepare and to conduct translational equity-minded research on stress, health, and resilience. I'm happy to say we launched this virtual training program 2 weeks ago. We have 125 trainees from across the world, 93 universities and institutions represented from 22 states and 17 countries. You can see the background of these individuals listed there. And I'm also very excited to say that these are really individuals from across the professional training continuum, from undergraduate students, graduate students, postdocs, faculty members, and industry and other areas. So these folks are learning. This is all free. We have a different lecturer every other week, and they're learning about basically the nuts and bolts of conducting high quality research on stress, health, and resilience. The second thing we propose to do is to develop a massive open online course. This is geared toward the general public to provide an overview of evidence-based introductory topics on stress, health, and resilience for students, professionals, but especially the public. We have several objectives that are all about basically understanding working models of stress and health and what people can do to reduce stress and improve resilience in their own lives. The core feature of the MOOC is lectures provided by 23 experts, which I'll show you in a minute. And 17 of those 23 lectures have already been recorded, with the final ones being recorded by mid-December. And we're hoping for a MOOC worldwide launch in spring of 2024. The experts, both from personal experience, but also from their content areas, were very excited to have what we regard as a highly diverse, highly engaged group of speakers that include current and former Surgeon Generals of California, and a whole list of other really exciting, interesting folks talking about stress, health, and resilience from, again, a personal perspective of lived experience, and also, of course, a scholarly perspective as well. We've also had a lot of scientific products and several papers come out the CalSTAR network this year. I just want to highlight a key finding from one of those papers that's currently under review, because I think it's highly pertinent to the work that we all do here. What we did for this particular study was downloaded the course curricula and course overviews from the top 50 US News and World Report medical schools that have programs that are population health focused. And we simply asked the question, are the top 50 population health focused medical schools in the United States today teaching medical students about topics related to ACEs, stress, adversity, health equity, and integrative frameworks? And if you see the x-axis there, the maximum is that 30% of these courses that we analyzed, there are about 250 of them, are addressing any of these topics. But the reality is that actually for most of these topics, such as resilience, it's less than 2%, life stress, toxic stress, abuse stress, most of these topics are not being addressed in medical school education today. So the bottom line for me is that if we hope that the healthcare providers that are being trained today are going to be more well-informed about ACEs, toxic stress, health equity, and stress and adversity than the current providers that are treating us, unfortunately, it seems like that won't be the case. So this is just formal medical education. It doesn't account for other rotations or clinical experiences that medical students could have received. But in terms of formal medical education, we're not doing a very good job. Okay, in the time that I have remaining, I'll just provide a quick overview of the research study that we're conducting. We have 2 primary aims. First of all, to quantify lifetime stress burden and examine mechanisms linking ACEs and health. And the second aim of the research study is to reduce ACE-related health disparities by developing, testing a precision stress management intervention. Just as a reminder, the overall study design looks like something like this. We identify individuals, up to 725 individuals that are high perceived stress score, greater than 15, which is about 75% of individuals. And we administer this consequences of stress scale to all of them, which basically identifies what their major biobehavioral pathway is that's being disrupted by stress. And we're focusing on 5 pathways: thinking style, social relationships, eating behavior, sleep, and physical activity. So the precision medicine part of this project is, for example, if David gets really stressed out and he stops exercising, then ideally from a precision medicine approach, he should get an intervention that focuses on physical activity. Whereas for me, I always eat poorly when I get really stressed out, so I should receive a stress management intervention that focuses on mindful eating. So we're following these individuals over 24 months. We developed from the ground up a precision medicine intervention that focuses on identifying the problem areas: cognitive response style, social relationships, eating, sleep, and physical activity. And people receive the intervention that is maximally mapped onto their problem area. Then they're actually randomized about whether or not they're going to receive that intervention or go into an active or a passive control group. The interventions are all online, totally scalable, totally free. They're 12 weeks, 12-week interventions. We then do a post-assessment follow-up, and then a 12-week follow-up after the ending of the intervention. We don't have any results to share yet, but I'll tell you the good news, which is that the project seems to be have participants who are highly very diverse in terms of racial, ethnic background, age, etc. We have 60 to 20, almost 25% of our individuals in the study who are over 50 years old, and some of who are 80 plus. Area deprivation index. So this is an index that takes into multiple factors, basically how deprived the local area is. 0 means highly advantaged, 10 means highly disadvantaged. And you can see the percentages there. We enriched for area deprivation index scores from 5 to 10. We have a very diverse sample in terms of socioeconomic status, family background, etc. In terms of household income, this is more normally distributed, but we have a good 20% of individuals under 50,000, mean household income under 50,000. Most folks in the 50 to 200,000 range. And so far, in terms of update of participant running, so we have a baseline only part of the study in which we want to recruit up to 425 individuals total. We just started a recruitment this month for the cross-sectional baseline study. We have 40 participants totally recruited and run so far, and aiming to have about a third of the sample done before December 15th. And we're running the clinical trial through 2 cohorts. So by the end of middle to end of December, we'll have half of the cohort completely through the longitudinal precision stress management intervention. It's all online, so the average coaching session attendance is about 80%. The module completion that they also are requested to complete is about 80%. And this is what the enrolled and attrition rates look like. We have about 47% of the total trial enrolled so far. The withdrawal folks, those who withdrew, are basically failure to launch. So they do an initial screening, but then decide that they don't have the time to commit or have other things that have happened. And then the folks who have dropped out are people who are actually enrolled in the trial, but then had to stop at some point midway through. So we're pretty happy with a community-based intervention like this of under 5%. We could probably do better, but we feel pretty good about it. And then this is a lot of data, but just to show you that these are all online intervention coaching sessions of individuals who don't come into UCLA or to any study site. So, we're hitting coaching attendance rates, these weekly sessions of anywhere between 80 to 100% attendance for most of these coaching sessions that folks are attending. And the same thing for the module completion rates, about 80 to 100% completion rates for the modules. And again, because these are highly scalable modules for us, we would imagine, if we're able to provide this free to the entire world and we were able to get 80 to 100% completion rates on average, we feel like we would be doing pretty well. This work has really taken a village and a lot of packing supplies. It's a totally virtual distributed study where nobody comes into UCLA. So we put everything in boxes. We send all of the widgets and gadgets, data collection kits, everything to participants wherever they are in the wild throughout the state of California. Personal exposome devices, micro blood sampling devices, continuous glucose monitors, stool sample collection kits, and all the other psychological and behavioral assessments. And we have an incredible team of undergraduates, 40 of them in total, who have all been a part of this study, and we're tremendously grateful for their ability to make this work happen. Thank you so much for your support, and we're just deeply appreciative to be able to do this work.
Thank you, Dr. Slavich. Any questions?
Pretty impressive.
Thank you, Nikki. Thank you, everyone.
Yeah. Just want to make sure anyone has time for a question if they want to ask one.
Simply echo Nikki. Lovely.
Don't put me between the questions and the break. That's a dangerous spot to be in.
Are you? Maybe I didn't catch. I saw the racial diversity, but I didn't track socioeconomic. In terms of the intervention, who is your audience in terms of who's uptaking this, and are you seeing big difference in socio-demographics in terms of who's attending classes, et cetera? You might not be there yet with your analyses. I'm just curious if it's being absorbed equally across class. And
yeah, so I don't think that we see any so the engagement is equal. The attrition across area deprivation index and all of the diversity categories is also equal. If anything, we see that for the older folks, there's some tech issues. For example, the wearable watch we're using is on the larger side. It's a research grade watch, and it's kind of heavy to carry around. I mean, quite frankly, I'm so grateful that we have any folks above 70, but many of them are not technologically inclined. So actually some of the challenges that folks have are more along the just participating in biomedical research category of things.
That really says a lot about the intervention and the engagement. That's congratulations.
Thank you. I think there was somebody else spoke up.
I was just gonna, I think, am I right that all of the biomarker data collection is like mailed, like they don't ever come into a laboratory or a clinic or anything like that?
That's right. And that, both for our sanity, during COVID times, but also really just for scalability and for the community embedded nature of the project, we really wanted to lower the barriers as much as humanly possible for participation for all of the diversity reasons that you can think of, but also because we wanted to make a very thin line between the research enterprise and the translational goals of the project. So the idea is that if you require somebody to go through an entire lab protocol in order to produce a toxic stress physiology report, then you're going to have a heck of a time turning that assessment protocol into something that could be scaled. So we really, from the design up, wanted to say, if we're gonna want to assess ACEs and toxic stress physiology in a way that could scalably and quickly translate into, let's say, worldwide case conceptualization and treatment planning, then we need to give folks a box that they can open with instructions that they can clearly follow and send samples back and never have to get on a train or a bus or a plane or anywhere, or find parking at UCLA, for God's sakes, or anything else, right? You just put it in the package, send it off, and we can profile folks wherever they are. And we think that's a very that's a goal, I think, that we wanted to shoot for in terms of having profiles that could be translated in and integrated into clinical care quickly.
Thank you, Dr. Slavich. We'll take our break now, and we'll cut it a bit short. So we'll come back at 2:45 and start back up again. Thank you, everyone. Hi, everyone. Welcome back from our break. We are, hopefully everyone's getting back from their break. We're gonna keep going. We have 2 more presentations, then the discussion before we have some closing remarks and end the symposium. So we have about an hour and 15 more minutes left. Our next presentation is from UCSF, from Dr. Nita Tucker. Dr. Tucker couldn't be here today, but I actually see she just joined. But I believe the plan is for several members of her team to give the presentation on her behalf. But I'll first start by introducing Dr. Tucker, who's an associate professor of medicine at UCSF. Her research and clinical work focuses on the role of social and environmental stressors on asthma and chronic obstructive pulmonary disease in vulnerable populations, with the goal of developing targeted interventions and therapies to improve related outcomes in vulnerable populations. One of her team members, Dr. Nicole Bush, will be presenting on her behalf. Dr. Bush is a distinguished professor of developmental and behavioral health in the departments of pediatrics and psychiatry and division chief of the Division of Developmental Medicine at UCSF. She leverages her cross-field training and insights from community engagement to innovatively bridge disciplines. Another speaker from the UCSF team is Dr. Omani Omotoso, who's an associate medical director of pediatrics at Lifelong Williams Jenkins Health Center and a volunteer clinical professor at UCSF. Dr. Omotoso is a primary care pediatrician with training in general pediatrics, public health, and pediatric infectious diseases. He's passionate about early childhood wellness by supporting patient families in a trauma-informed and resilience-focused holistic approach. They're also joined by their team member, Rosemarie De La Rosa from UC Berkeley. Take it away.
Thank you. It's a pleasure to be here. And Nita's been on call and we're glad she can be here, but she wasn't sure she'd make it. So I'm Nikki. I'm happy to share this with you and tell you a bit about our care study. To remind folks, we had 3 aims. The first one, I'll just...
Sorry to interrupt. We're seeing the presenter view.
Oh, thanks for letting me know.
Yeah.
How's that? Better?
That's much better, yes.
Okay. Let me just get my slide on the right thing. Okay. So we have 3 aims of our project, and the first one was to follow up an extant cohort. I'll tell you a little bit about that, where we're estimating the impact of childhood adversity on biologic and health outcomes. Our second aim was to trial an RCT of 3 different child caregiver interventions across 3 different contexts in pediatric primary care. And our third aim was around developing a resilience toolkit with our community partners. I'll tell you more about each of those in a moment. Our care leadership team is across the state of California. These are the PIs from Oakland, San Francisco, and Santa Barbara, as well as Lisa James, our community partner PI from Futures Without Violence. And we are but a very small percent of the effort that is involved in implementing this very large study. And here I just want to highlight across our aims how many incredible people contribute to the data that I'm about to share with you today and could not be here without their heart and soul labor of love. Okay, so our first aim, the goal was to follow a prior extant cohort that had really rigorous longitudinal data, including the Pearl screener, as well as biomarkers and health outcomes at baseline and then 9 months later. This cohort was 3 months to 11 years of age at enrollment, and it was drawn from the Oakland Federally Qualified Health Center. So it was a predominantly Medicaid population, Black and Brown communities, and had a very high report of adversity experiences and a lot of low income in this community. And so what we found is that with support from this award, we've been able to, after a year and a half of recruitment with some delays to start, we're happy to report we've enrolled 178 of these original participants, roughly 5 years after their baseline assessment. And for us, that means we have about a 60% acceptance rate to date, which we're feeling very good about. That's very close to what we estimated. And we've even begun our T6 visits, which are showing us a 93% retention rate from those we were able to re-engage in this follow-up study. So we're feeling pretty good about how things are going and really making a lot of progress there, especially after we were able to increase staff efforts for these follow-up calls and efforts. Let me tell you just a little bit about some of the findings that you can expect from our data. In recent analysis led by Dr. Kamampa from our team, we evaluated the association between a child's baseline PEARL score and their measure of executive function about 9 months later. We used the brief P, which is a parent report of children's executive function impairment. So a higher score means worse functioning. And we broke the kids into 2 groups, those that had normal EF at both time points, baseline and 9 months later, or those who had a normal score at the second time point. In the other group, we had those who were in clinically impaired levels at both time points or impaired at the second time point, so a worsening trajectory. And what we found is that there is a significant continuous association between PEARL score and executive functioning. But over on the right, if you break our population's PEARL scores into quartiles, and Pat had mentioned his PEARL scores in his cohort, we find that a quarter of our sample has 5 or more on the PEARLs, and this is in childhood. We find that there is a significant difference for those that had 5 or more relative to those that had 0. There's quite a significant difference in executive functioning there. And so this we are interpreting as the PEARL score being a good tool to use to predict poor or worsening executive function in child patients within a primary care pediatric setting. On this slide, we're summarizing some of the biomarkers that we've either already measured from our prior study or used some of the funding now to measure or collect additional specimen here. The table on the left lists some DNA-based and clinical lab biomarkers to give you a sense of some of the things that we have. Highlighted in green is our ongoing collection of that wave I told you we have 178 kids so far within. And of those, we're just starting to measure telomere length and buccal DNA samples and able to analyze longitudinal trajectories at this biomarker. On the right is plasma biomarkers that are measured both at baseline and the 1-year follow-up. So you can expect a whole range of papers to come as we get all of these data lined up and are able to complete assays across multiple waves to really have a better sense of the longitudinal prediction of the PEARL score, as well as the stability of some of these biomarkers and health outcomes in our child population. And because of support from this award and other funders, we've already been able to generate results examining toxic stress and response to the PEARLs in the PEARLs cohort. And we previously showed that PEARL scores are associated with allostatic load or cumulative wear and tear in children, and that work's about to be published. But we also have some very recent work that's showing the PEARLs was associated with buccal cell telomere length, which is a marker of cellular aging. Not as a main effect, however, what we're finding instead is that the residential air pollution, or PM 2.5, is associated with shortened telomere length or increased aging. But in particular for children who have average or above scores on the PEARLs. So it's modified by social context subdomain scores on the PEARLs. And that includes things such as neighborhood violence, discrimination, housing insecurity, and food insecurity, suggesting that that pollution effect is really salient for those who are struggling with social context high scores. And Dr. De La Rosa is on the call now if there's specific questions about those findings in Q&A. Jumping to AIM-2, this is our randomized controlled trial, and we have 3 different intervention types across 3 different settings in California. In Oakland, we have Resilience Clinic, which is a group-based circle of security, mindfulness, and co-regulation group. In Richmond, we have the ABC Attachment and Biobehavioral Catch-up Intervention, which is an individual, family-focused, home-based intervention, 10 sessions. And in the Santa Barbara neighborhood clinics, we have the Resiliency Family Program, which is a clinic-based 4 sessions. So this gives us an opportunity to compare the different regions of California, but also different delivery styles and whether they all work or just one was the best, et cetera. This is just a little map of kind of our study and how we do a pre-intervention questionnaire after enrollment. And then we do a pretty intensive 2-hour clinic visit, assessing a whole lot of biobehavioral markers, including specimens such as saliva, buccal, and nasal swabs, and a venipuncture blood sample for later assay. We conduct the intervention. We do a post-intervention questionnaire, and then a 3-month post-intervention 2-hour clinic that's the same as our baseline. And at the end of the study commitment, the wait list is then offered intervention. It's a waitlist control group. And just quickly to highlight where we're at so far, as shown in the other slide, although very delayed by the pandemic, we're off and running. We have 32 families enrolled in the intervention at the Richmond Lifelong Clinic, 30 at the Oakland Benioff, and 19 in Santa Barbara. These children, again, are between 2 and 5, and we have quite a diverse enrollment, although it does vary somewhat by site, in part because of the patient population served by those clinics. For example, you can see that it's 71% Hispanic at Lifelong versus 36% non-Hispanic Black in Oakland, and a little bit more white representation in Santa Barbara relative to the other 2 sites. But you'll note on the bottom, they all are experiencing relatively high levels of pearls given how young these children are. We also have great data on our behavioral and mental health outcomes, as well as biospecimen that we'll be tracking. And we have pretty good data collection and completeness. They are experiencing a lot of stress and some significant problems. Here we're seeing some variability by site in terms of how the biospecimen collection is going. Some sites are just slaying it, and other sites are learning a little bit more how to implement this type of biospecimen collection in their primary care context. So we're feeling good about that. And now I'm going to hand this over to my colleague, Nii.
Thanks a lot, Nikki. Yeah, so the aim 3 is about the resilience toolkit and how do we set this up for use in low resource primary care clinics. And so there are kind of 3 main things we kind of looked at is staff facing, patient family facing, and then also community engagement. And so for the staff facing side, we put a lot of time and resources along with our Futures Without Violence collaborators to facilitate a series of staff trainings, more on ACEs and toxic stress, psychoeducation, and then also helping staff cope with how to deal with secondary vicarious trauma and what kind of self-care strategies are involved. And then the other trainings focused on aspects of how do you roll out screenings, how do you educate families about them, how do you interpret and discuss results and provide ancillary guidance. And then we created a work group, which consisted mostly of primary care providers and medical assistants that helped us to kind of adapt our own workflow for how the screening process and interpretation was going to go at our clinic. And then we set up a series of regular check-in meetings so that we could tailor the workflow in terms of how patients responded to it and what we're finding in our clinical experience as well. If you can go to the next slide, I'll talk a little bit more about in terms of the patient family facing side. So we wanted to make sure this was very patient engaged and centered. And so we created a family board, advisory board, which helped us kind of throughout this project, taking at least 4 caregivers from each of the 3 sites and set up meetings where we did a little bit of education on ACEs and toxic stress and what the study was about. And then started to get a lot of input from them in terms of how we presented the screening, where it was done, what setting, also how they would like it to be discussed afterwards in terms of the results and what kind of resources would be most beneficial for them and in what formats they would like it to be in. And so the main things we found was most people thought they wanted it to be done in private, which meant when they were in the clinic, in the exam room, and they wanted the staff, which was usually the medical assistant or provider, to discuss it with them and explain verbally what it was about, in addition to written instructions. And then another piece, which we hadn't mentioned earlier, was also trying to promote resiliency. And so we also included with the screening tool a series of questions that focus on strength-based factors. And so these were things that were discussed with the parents, during the interpretation of the ACEs screen. And so the families were grateful that we also discussed these positive things as well, not just talking about the ACEs or toxic stress. And then what we also noticed was they also wanted us to talk about this afterwards, and so sometimes we actually set up separate follow-up visits just to discuss kind of how the family was coping with the ACEs or with toxic stress they were dealing with. And so we were able to do some interviews afterwards, kind of a qualitative analysis to get more input from families that had been screened. And this is a couple of samples of quotes we got from them on what the screening experience was to them. So for our study, we're doing it in early childhood. And so for us, positive ACEs was anything above 0. And so we also realized early on that some of the screens were coming back negative because the 10 ACEs is not a comprehensive list of ACEs and also doesn't account for a lot of toxic stress families endure. And so we regarded a positive test was if any of the 10 questions were positive or the part 2 that addressed some social determinants of health was positive. And so we then offered services to those families. And so we created a way where we had, in essence, kind of a community health worker to help provide families with resource navigation and linkage based on what the need was. And so we kind of collaborated with local community-based organizations to find out what kind of resources were needed and how to connect with them. And so if we look at the workflow on the far right, for example, for food insecurity, we talk about needs like acutely today and also short or longer term. And how do we try and address both at that visit? And so we also made sure we created a system where there were follow-ups with the families, either by phone or in person, over a series of time to make sure those needs were actually met. And created also pamphlets for all the different resources so that even at that initial visit, the provider talking to the patient could provide them with a resource list while they wait for the process of the referral taking place. I think that's it.
Okay, thank you. Sorry we went a little bit over. We're trying to cover a lot of NEAT stuff, so we're not as fast.
No problem. Are there any questions for Dr. Bush or Dr. Omotoso? Dr. Marie Mitchell, I see your hand up.
Yeah, 2 questions. So I guess for the first aim, I think if I caught that correctly, the association was between the social determinant questions and the biomarkers, but not between the ACEs and the biomarkers. Did I catch that right?
Sorry, do you mean related?
Yeah, that slide
Rosie,
7.
Yeah, Rosie might be the best person to answer that question. I think with our recent paper looking at the different domains within the PEARLS tool, we were able to bring that newer finding of seeing these 3 constructs within the PEARLS with maltreatment, household challenges, and social context. And then I'll hand it over to Rosie to answer your question specifically because it was something that we noted as well.
I also just threw in the chat the domains paper in case anyone's interested in how you contextualize that. But this is looking at, we didn't see any associations at this baseline visit. We think that's possibly because of the age of the kids. But we did see an association between air pollutants, so particulate matter, and telomere length, and that was enhanced among the kids who experienced higher amounts of social context adversity.
Social context, right.
Yeah, which is the domain that encompasses these listed PEARLS items.
Okay. And I guess my different question was on the second section on I was just wondering what the in terms of research recruiting, what are you advertising to? This is for AIM 2 now. What you're advertising for people to how you're advertising and what the incentives are for participation.
Yeah, so we are working through the workflows of the primary care of each clinic. So each of these clinics has PEARL screening as part of their workflows. And then for those that have 1 or more PEARLs, they're referred to care navigation, which is not an element of the research study. It's a service that are either enhancing at the sites, as Dr. Omotoso outlined in sort of a toolkit for implementation, or through care coordination that's already provided through the clinics. And then those families are told about the study, and for those that are wanting to participate are invited to participate. The compensation is more tied to doing the study visits as opposed to the intervention itself. So we don't usually compensate for the actual intervention, but for the study visits, it's about $80 for the baseline visit. And then there's a small incentive for completing the 3-month surveys, which are more telephone or web-based surveys at $30. And then the full complete study visit, which is 6 months after interventions, is again $80, which is an in-person visit. We do also offer additional money for travel, for knowing that it can be difficult for people to pay for transportation to these visits, that we can offer an additional amount. This is on par with what we consider to be non-corrosive but also meaningful, given the number of how much time it takes for people to come, and kind of thinking about what's many of them are working in hourly jobs, not salary jobs. So trying to also balance those costs that they're taking to be part of the study.
Thanks.
Any other questions before we move on? Okay. Thank you. So the last presentation today is from UCSD, where the lead PI is Dr. Gary Firestein, who's a Senior Associate Vice Chancellor for Health Sciences, Director of the Altman Clinical and Translational Research Institute, and Distinguished Professor of Medicine at UCSD. His research focuses on the pathogenesis and treatment of rheumatoid arthritis. And as Director of the Research Institute that I mentioned, which supports nearly every clinical trial at UCSD with personnel, infrastructure, and informatics, he oversees community engagement efforts. Dr. Kay Rhee will be presenting on behalf of Dr. Firestein and the UCSD team. She is Professor and Vice Chair of Equity, Diversity, and Inclusion at UCSD School of Medicine, Department of Pediatrics, and Chief of the Division of Child and Community Health and Medical Director of the Medical Behavioral Unit at Rady Children's Hospital, San Diego, and the UCSD Center for Healthy Eating and Activity Research. Dr. Rhee has special interests in childhood eating and weight-related disorders and has multidisciplinary training in childhood obesity treatment, behavior modification, parenting skills training, motivational interviewing, epidemiology, and social psychology. They are joined by team members Dr. Eric Heckler, Blanca Meldrez, Jessica Chapman, and Cynthia Juarez Nunez. Let's take it away, Dr. Rhee.
Great, thank you so much. Let me just get my screen. Are you guys seeing that?
Yes.
Okay, great. All righty. So yeah, thank you. I'm heading up the end here, so I'm going to try to make it short and engaging, and then leave it up for a lot of questions so we can get to the more fun part of this meeting, I think. So you heard a little bit about our team. This is our team. Dr. Firestein is here. We also have Blanca Melendrez here, Jess Chapman, Eric Heckler here, and unfortunately Cynthia, who is our wellness coordinator, is not able to make it today. But in addition to that,
Cynthia is here. Sorry,
oh,
Kate.
Oh, great. So in addition to that core research team, we have a ton of other people who are involved in creating this project and putting it together and actually getting it to work. And so I'm just going to highlight a few of these people. So Claire, Liliana, and Dana were instrumental in getting us, started in this program, creating the protocols, making sure we had all of our I's dotted, T's crossed, getting everything set together. During the process, we also engaged and hired several promotoras. Yadian and Dulce are part of our team as well. So they are part of our promotora network, which you'll hear a little bit more about later. And then we also had a large team of co-investigators from the community. This is just a few of them. David Boyle works at the CTRI and it manages our biorepository. Pradeep Gidwani is our AAP representative for San Diego County chapter. I forgot what chapter we are. We're down south in San Diego. And then Margarita is a community champion, runs a promotora network, has been involved involved in numerous research studies and is one of our go-to people whenever we do this kind of work. And then, as all of you guys have highlighted as well, we have multiple research assistants, students who are helping us get this work done. So I'm just highlighting a few of them here. Many of them are part of our School of Public Health at UC San Diego and our community partners. They were, again, instrumental in helping us design this program, really telling us like what is needed in the community and what other aspects of the project we need to include to make this a robust project that also really gets at like what we're all trying to do, sort of the individualization of the intervention so that we're really addressing the needs of the family and not just doing a one size fits all for everybody kind of program. So our program is called the Healthy for You ACEs Project. And as I mentioned before, we really try to develop collaborations, build upon existing collaborations with our Latino communities, with our several promotora networks, with our community clinics. And we partnered with the Family Health Centers of San Diego, which is our FQHC down here in San Diego County. And then obviously the UC San Diego researchers to really create a more behavioral medicine, precision medicine, community-based approach program that really addresses childhood trauma, tries to build resiliency around toxic stress. And I'll talk a little bit later. We really do focus on the social determinants of health aspects of the PEARLS evaluation. And then we decided to also focus this around childhood obesity. I think most of you know the relationship between ACEs and childhood obesity. Vincent Folletti is down here in San Diego. I'm really kind of informed part of this work as well. And so all of this work that we were sort of built upon existing programs at the FQHC, targeting childhood obesity, but really addressing the ACEs and social determinants of health aspects that contribute to this entity. So as I mentioned, we were really trying to build off of what already existed in the FQHCs. And so they have a program called Healthy Togethers. And this is a program where they were really trying to address obesity in the traditional sense, right? So they had, talked to us a while ago before and really developed this program that focused on healthy nutrition, diet education, physical therapy. At the FQHCs, they're able to implement exercise sessions with their physical therapists. So they had this core program. And in addition, because it was at the FQHCs, they were able to also involve monthly navigation sessions with the families where they were meeting with sort of like a wellness coach and talking about, what referrals they needed in the community, what other referrals they needed to address their social determinants of health issues and things like that. And again, because they have such a robust multidisciplinary aspect to their pediatric care there, they also were able to have a mental health assessment tied into this program from the get-go. And so that was where we kind of started with this program. With that, and I don't know if you're, so with that, when we're thinking about the social determinants of health aspects, ACEs, all the different contributors to stress in a child's life and development, one of the things that we kind of look to is what other programs are there that can help, with promoting, healthy child development. And one of those programs is parenting training programs. So there are things out there like Triple P, Incredible Years program, things like that. So one of the things we wanted to do was try to incorporate more intensive parenting training into our program to see if that sort of behavioral intervention helped with regards to any of the social determinants of health outcomes and child development outcomes. In addition to that, the other thing that we were hearing quite a bit from our community and from the other clinicians and staff at FQHC was this real need to help families navigate the system. and have sort of that care coordination, individualized, for those of you who do behavioral research, behavioral coaching, more of an individualized approach to help families navigate, accessing resources, implementing the changes that they needed to change and things like that. So we partnered with our promotora networks and engaged with them to be the care navigators for our families. And so they have weekly sessions with some of our families, and we taught them a little bit of motivational interviewing. We talked to them about the circle of, Eric, you're going to have to help me here. I'm blanking on the word right now. The circle of security. Thank you.
Circle of security.
So, circle of security. We did a lot of different trainings with them to help give them the skills and help them feel confident to work with our families and address whatever needs came up. So they are doing that as well. And then in addition to that, we really wanted to develop a resource list of all the different resources in the San Diego community that we could help these families access. And so we partnered with Streetwise, and they helped us develop, they're actually helping us right now, sort of assessing all the community resources that address food insecurity, housing insecurity, transportation, things like that. And they're working through this process now where they're getting stories from families and really getting feedback from families in lots of different neighborhoods around San Diego County to help us build sort of this reference group. And so in our intervention, we're actually randomized. So everybody in our intervention, if you can see my arrow, will get this middle piece here, the Healthy Togethers program. This is the core that everyone will get. And this was also important for our community, that families don't get randomized in the traditional sense and get nothing like a control group. So everybody was going to get this Healthy Togethers program and have access to the information that we got from Streetwise. And then they were going to get randomized to receive parenting training plus Healthy Together, promotoras plus Healthy Together, or a group that got Healthy Together's parenting training and promotoras. So we have basically 4 different intervention groups that families are going through. For inclusion criteria, again, we wanted it to be more inclusive than not. And so I'm a pediatrician. We are focused on childhood adverse events. So these are our inclusion criteria. We did focus on the ages of 4 to 12 because the parenting training programs often focus on the younger age group. And so for this to be more applicable, we decided to focus on children who were in the 4 to 12-year-old range. We also were focusing on kids who had overweight or obesity, and then had a score of at least 1 on the PEARLS assessment, or the whole child assessment, or the physician identified that this family had an ACEs, even though it might not have been reported in the PEARLS. If the physician sort of guaranteed that there was an ACE, we also would include them, because as you all know, a lot of families don't always report everything on the PEARLS. And so we wanted to be able to include those families if a physician really advocated for them. For parents, because this is a dyadic intervention, we need a parent and a child to participate. You can see the parent inclusion criteria here. We are also focusing this program for Latino families in San Diego County who go to one of the FQHCs in a certain region. And because most of the families who go to those FQHCs were Latino, we decided to focus in on that population as well. Exclusion criteria were pretty limited. We tried again to balance this between the rigor of a traditional clinical trial, but also allowing as many people to participate and potentially benefit from some of these programs as we could. So we really limited exclusion criteria to anything that would prevent families from engaging in the full program as we were wanting to offer. So at this point, we don't have a lot of preliminary data to share at this point, but I did want to just highlight some of the recruitment and retention numbers that we have right now. So we have had about 150 families referred to us from pediatricians. We've been, calling them, trying to get them in for initial assessments and things like that. As of now, we have about 89 families who have signed or who have enrolled and have been randomized to one of the 4 groups that I mentioned. One of the challenges we had, and I saw Jess put in the chat earlier, is getting some of the biologic samples. So we've been sort of pairing our research blood draw with the clinical blood draw that's already happening, because all of these children have overweight or obesity. And so right now, every pediatrician is recommending that a child get a blood draw to measure hemoglobin A1C and those sorts of things. We've had about 63 families who've done both the clinical labs and the research labs. We've had about 13 families who are opting to just do the clinical labs at this point. And this intervention I failed to mention before is a 6-month intervention. So at this point, we have about 18 families who've completed the 6-month intervention. And we're going through the process now of having them complete post assessments and going through an interview process with some of our staff just to get feedback on the program. What did they like? What didn't they like? Was it overburdensome? Did it actually address any of their needs? That's the kind of feedback that we're trying to get so that we can ideally, modify this program, adjust it so that it really is meeting the needs of the family, because all of these components we believe are going to be helpful to some degree. The question is whether all the families are going to be able to access this, and do they really think it's helpful at the time that they need it? And so again, that tailoring aspect of being able to provide all of these things, but who needs it? When do they need it? Who's going to benefit most from these kinds of interventions? That's kind of what we're hoping to do as we go through the rest of this trial. I wanted to just pause for a second and see if Eric, Jess, Gary, if any of you wanted to add anything about the intervention or the program before we open it up to questions.
I think you did great. Okay. Yeah. Okay.
I agree. Thanks for the great summary.
Of course, as with you, we all have a lot of things we could share, but also mindful we only had 10 minutes. So I want to respect the time.
Right.
We have time for 1 or 2 questions then. Do we have any questions for Dr. Ree or any members?
You never know if that's good or bad. Either it was crystal clear and it was a beautiful presentation, which it was, or it wasn't. But I think really it was amazing progress in a program that required extensive efforts on all stakeholders' parts to come together and generate a protocol that would be feasible and also hopefully make a difference and be accepted within the community and could be accomplished in a clinical setting, which was quite a challenge.
And also be sustainable. We actually built everything with the frame of mind of it's not research or dollars actually paying for the intervention work. So, and if there are no comments, I will throw in this. There's some really fascinating stuff we're learning from the Streetwise data, where I could briefly show you an image of what it looks like just to give you a sense of this. This is, basically this is, as I said, it's like Yelp. The blue are actually good things. The red are bad things and the purple are fixed things. And so this is in central San Diego. Critically, the thing that you're noticing here, about 60% of the comments that community members are offering are actually positive about their areas. And this is specifically in areas that are often have high social vulnerability index scores. So areas that you might not think of as having that sort of perspective and whatnot. And so we're not only are we using this as an intervention strategy itself for community members to receive this and basically be able to see these ratings and other sorts of work, but then also we're working on developing out like a coding scheme. So you can think about it more as like an exposome, and there's a variety of coding strategies and things like that that are coming from it. Even I can briefly show you there's this one thing, but don't quote me on this. Oh, I guess you're recording. Just don't share this too much. We're just in the midst of doing codings. We've developed a variety of coding schemes. And so what we're doing is one of my students is building system maps of all of the different comments. This is in City Heights, one of our neighborhoods. And like you can see like the ways in which these issues of lack of sense of safety kind of bubble through communities. And you can kind of actually see these linkages through the comments and communities that are doing so. Anyway, just some fun stuff. But again, we don't have time to go into all these details. So.
Thank you, Dr. Heckler, for providing that additional information and very interesting visuals. With that, we'll kind of conclude the presentation portion of the symposium. I just wanted to thank all our speakers, all of you for listening and participating and carrying on this research, as well as all the children and families involved in this research.